Okay, I don't think I'm going to really need 2 hours or 2 class periods today. So if I see it at about 3, I can probably finish in about 10 or 15 minutes. I'm just going to continue. That'd be okay. Now, again, I'm not certain, but I got to ask you, the last time I gave you some things to focus in on, did it help? It did? Okay, because I thought about doing that again, about what to focus in on, and some very specific things also that I just want you to know something about it, because there's a question about it, and it's not mere memorization. You know, it's a little bit more than that. Okay, I've gone through basically everything here that it's in white, and things that are in red are still things that I just need to go over. Now, while it seems just a few in number, these might be some of the more important aspects of breast cancer. But in order to do this, let me just go back to this particular case. I left you with the patient being diagnosed with breast cancer, and then there was some kind of plan that was going to be made. But here we are now having a little bit more specifics about the woman's disease. It is a small tumor, and as you can see, just by tumor size, it will probably be a stage 1. Her node, the sentinel node, was positive, and again, from a prognostic perspective, positive nodes is good or bad, or poor or good. Anybody? Poor, right? Poor. You see that. ER and PR were both positive from a prognostic perspective. Good or bad? Good, right? It's good. Okay. The HER2 was negative, and again, from a prognostic purpose or perspective, this is good. HER2 negative. Now again, while it has prognostic importance, both ER, PR, and HER2 have also predictive importance, i.e. it helps guide therapy. So the thing that this woman will not get is anti-HER2 therapy. What is clear though, because both ER and PR are positive, that if she gets chemotherapy, she will also get hormonal therapy. And that's part of standard management. So again, if you look at the patient here, she has early stage disease, potentially curable. I asked the question, what would be the rationale for giving her systemic adjuvant therapy? Now for certain, she's going to get hormonal therapy. But what about chemotherapy? What are your thoughts? Should she get chemotherapy? And this is in the absence of doing oncotype. Should this woman get chemotherapy in addition to hormonal therapy, in spite of the fact that she has early stage breast cancer? In other words, look at what's potentially poor in terms of overall prognosis. 1, node positive. From my perspective, that might be the most important, but there's another important prognostic factor here, and why I think she should get chemotherapy also. And that is, Sarah? Besides the node, what else about her that sort of steers you or leans toward giving her chemotherapy? I'll tell you, some of you may already know this, it is her menopausal status. Remember I told you that premenopausal women tend to have a more aggressive disease than postmenopausal women? Her young age, she was 41. Her young age, again, suggests that this is a more aggressive disease. And if you look at it from a different perspective, her mother also had breast cancer, and the mother died at a young age. So, considering all of these things, giving her adjuvant chemotherapy, in my opinion, is most appropriate in addition to give her hormonal therapy. Now again, when we think about hormonal therapy, and I put there, if endocrine therapy is going to be given, and there's no question about that, it's going to be given, when should it be given? When you also be giving chemotherapy? Anyone? Take a guess. Should we give it 1, concurrently, or 2, sequentially after chemotherapy is finished? Usually it's 4 cycles of chemotherapy and then that's it in an adjuvant setting. Jason, what do you think? Concurrently or sequentially? Okay, that is correct. That is correct. That is how it is being done now. But the reason behind that is that there are some studies to suggest that giving hormonal therapy, even aromatase inhibitors, can antagonize the effect of chemotherapy. And hence, that's why they give it sequentially. Now again, not all the studies have shown that, but one major study has shown that the responses or outcomes were poorer in patients who got concomitant endocrine chemotherapy compared to those that got chemotherapy followed by endocrine therapy. In part, it's because if you look at where tamoxifen works, it tends to work in G1, so it halts cells in G1, and most of the chemotherapy work in S phase. So part of the reason is the antagonism of the hormones with chemotherapy, and hence, just remember this now, if it's going to be given, chemotherapy plus hormonal therapy should follow chemotherapy. Okay? Follow chemotherapy. All right. Now, as you know, if she chooses to go on to hormonal therapy, the drug of choice is going to be in this woman, not an aromatase inhibitor, but tamoxifen. All right? Now, is there a role for oophorectomy in this patient? And more newer studies suggest that combined tamoxifen therapy plus oophorectomy may be better than either one alone. So it's conceivable that this woman could have what they call complete estrogen ablation by removing the ovary as well as giving an anti-estrogen. But it is not mandatory. It's still in clinical trials, but the early data suggests that they do better. Okay, I'm going to leave the last part out in terms of Zolanta bisphosphonate because I'm not going to ask you a question about that. Okay, so here's just a diagram that you have seen before. It is clear that if a patient is ER negative, node positive, premenopausal, she should get adjuvant chemotherapy. All right? If she is ER positive, node positive, in my opinion, she should still get chemotherapy. Where Oncotype comes in is in this group, ER positive, node negative. Why? Because the ER positivity is a good prognostic feature. HER2 negativity is a good prognostic feature, suggesting that some of the women will not need chemotherapy. So they do Oncotype on this one, especially. Okay, this holds true for postmenopausal women also. Now, let me just tell you one thing that has happened, at least over the past, let's say, decade, more so than prior to the year 2000. Prior to the year 2000, if a woman was considered postmenopausal, some of the oncologists were rather reluctant to give the patient chemotherapy, suggesting or implying that older women do not tolerate chemotherapy as well as younger women. And to a certain extent, that's true. However, I think there's been more of a push now that if a woman is biologically in good condition and chronologically a little bit older, nonetheless, you give them chemotherapy because they tend to do just as well as the premenopausal females. Okay? So I don't think it's absolute now. Just because a woman's, let's say, over the age of 60, if that's what they consider to be old, that no chemotherapy is given or milder chemotherapy is given. You give them what the premenopausal women would have gotten. Okay, and there's been a push now suggesting that giving chemotherapy to postmenopausal women, they do just as well in the long term as premenopausal women. So whatever you give in premenopausal women here in terms of systemic adjuvant chemotherapy, you give to the postmenopausal women. And I'll come back to some of the regimens, which I don't expect you to have to memorize though. But I'll give you some idea about what they do here in patients who receive chemotherapy. Okay, remember again, HER2, Prognostic, predictive, ER, prognostic, predictive. Okay? ER negative, HER2 negative, no hormonal therapy, no anti-HER2 therapy. It's simple. It really is simple. Positive, you get it. Negative, you don't get it. Okay, now you don't have to memorize this. I listed this in order of popularity of regimens. This does not necessarily mean that AC is better than sequential ACT. These are all what's considered to be equally good regimens, although this one is probably the most popular, the AC regimen. So, here's doxorubicin, cyclophosphamide, reverently known as AC. You talk to any oncologist, they know what AC is. It's this DCTC that makes it a little bit confusing because this D stands for docetaxel and this T stands for docetaxel. The reason why is the trade name of docetaxel is Taxotere, and they didn't want to have two DCs. Okay, but these are all good chemotherapy regimens to be used in an adjuvant setting. Usually after surgery, patients get 4 cycles of chemotherapy once every 21 days. Now remember now, if the patient's HER2 positive, you add on trastuzumab here. So the regimen becomes TCH, Herceptin. Okay? If the patient's ER positive, you add on, depending upon menopausal status, tamoxifen or an aromatase inhibitor. So it's pretty straightforward. Okay, but again, you do not have to memorize this. I will give you cases or small scenarios, short scenarios, about a woman who may require adjuvant therapy, and I'll tell you what they're going to get. And I'm not going to lead you down the wrong path. The only thing I'll ask you is, should they get endocrine therapy also? Should they get trastuzumab also? But you'll know it just by looking at the case. All right? ER positive, endocrine therapy, HER2 positive, HER2, anti-HER2 therapy. Straightforward. That was chemotherapy. This is endocrine therapy in the adjuvant setting. And again, depending upon menopausal status, it differs a little bit. If the patient's premenopausal, endocrine therapy of choice, Ryan, is tamoxifen. Yes, Ryan? Wait, hold on. Let me just get close. I have a right ear infection.
Can you repost the slides that you didn't give us after class?
For you, Ryan? Yes. Yes. Okay, tamoxifen, again, is the accepted standard. If you ask a woman, if both of these are considered to be equivalent, tamoxifen versus taking out the ovaries, almost always the woman will opt to take the tablet. And I don't blame them if it's equally effective. But I put here again, tamoxifen plus minus oophorectomy. Could undergo both if they're on a clinical trial. All right, in a postmenopausal setting, the treatment of choice today is likely to be an aromatase inhibitor. But, a big but, this does not necessarily mean that tamoxifen can't be used first line. It can still be used first line. Okay? It's just that more doctors are opting for this one because of clinical trial data, but the data have shown, this is what the data have shown thus far with the aromatase inhibitor. It has improved progression-free survival, but it has not improved overall survival. Besides that, these drugs are not side effect free. They appear to be somewhat, or have somewhat a better profile, tolerability profile than tamoxifen. In other words, it's not carcinogenic. It's not associated with endometrial cancer. It's not associated with thrombosis, but it does have its own side effect profile that can be dose limiting or treatment limiting. Okay, I put here or tamoxifen, but most people will select this one, the aromatase inhibitor, in an adjuvant setting. Okay, let me move on now to this particular receptor. HER2 was probably discovered in the late 1980s, early 1990s. At that time, they really didn't know what the significance of this particular transmembrane receptor was. What we do know is that on normal cells express HER2, but that's not the only place HER2 is expressed. HER2 is also expressed on myocardial tissue. And hence, this is thought to be part of the reason why anti-HER2 therapy has some cardiac effects. Because what happens through HER2 here, signaling or myocardial tissue, is normal tissue development or myocardial tissue development. So if you block that, you could potentially have cardiac dysfunction. So that's a known toxicity of all anti-HER2 therapy is on the heart. But in normal breast tissue, HER2 is expressed also, but it is not of any significance. It is believed to convey some important developmental impact on ductal development, epithelial development, etc. So, even though it's expressed on normal breast tissue, it is when it's overexpressed. And when I'm talking overexpressed, the numbers are significant. It is currently believed that on normal breast epithelial tissue, and you don't have to remember this, there are approximately 20,000 HER2 receptors per cell. But in an overexpressing breast cancer, there are over 2 million HER2 receptors expressed. The numbers are not important for you to remember, but in overexpressed breast cancer, HER2 overexpressed breast cancer, the numbers of receptors are logarithmically much more than in a normal epithelial tissue. Okay, so what happens? What we know also is that there are a number of other HER family members that are expressed on normal breast tissue, such as HER3, HER4, and epidermal growth factor receptor, which is also known as EGFR, also known as HER1. So HER1, HER2, HER3, HER4. They're all expressed on breast epithelial tissue. The one that's most significant, at least at this point in time, is HER2. Okay, so here's a HER2 overexpressing breast cancer cell line. What happens is that, and I'm not sure if you went over this with Dr. Newton or not, but let me just reiterate this. HER2 or any of the transmembrane receptors do not function as a homodimer. I mean, not a homodimer, a monomer. What must happen is that these receptors must dimerize with another. And in this particular case, this is a HER2 homodimer. Once it homodimerizes, they are then, the kinase domains are phosphorylated and then signaling begins. So it's the dimer formation that causes signal transduction. So this is, because of the importance of HER2, this was the first targeted agent to appear. I'm sorry, I don't want to say that, because I already told you that tamoxifen, in my opinion, was the first targeted agent in breast cancer. This is the first new biologically targeted agent in breast cancer called trastuzumab. This became available very early on in 2000, and it has had a profound impact on the treatment of approximately 20% of all breast cancers. HER2 is not overexpressed in the vast majority of breast cancers. Only about 20% of the breast cancers are HER2 overexpressing breast cancers. So trastuzumab here is a monoclonal antibody that targets the external domain of the receptor. And again, it usually is used in conjunction with chemotherapy. Now let me caution you. And Dr. Newton may put this question on the exam, so I want you to get it correct now. If trastuzumab or any HER2 therapy or anti-HER2 therapy could potentially have an adverse effect on the myocardium, i.e. resulting in congestive heart failure, what chemotherapy agent should trastuzumab not be given concurrently with? Brian? Yes. Anthracyclines. Did you say that?
I said doxorubicin.
Doxorubicin is fine. Doxorubicin is fine. Doxorubicin is fine. Now that makes sense. That makes sense. So while AC is traditionally used in the adjuvant setting or even in the metastatic setting, if that's going to be used in an adjuvant setting and the patient's HER2 positive, the trastuzumab is not given concurrently with AC. Okay, it is given after AC is finished. And again, the clinical trials have shown that when they initially gave it, AC plus H together concomitantly, that there was a higher incidence, approximately 25% of the patients developed cardiac ventricular abnormalities. It was that high. Okay, so basically now what they've done was they've separated any anti-HER2 therapy in patients who are getting anthracyclines. So from your perspective, I think you should know what are some anthracyclines, although doxorubicin is probably the most popular one. Okay, I suspect Dr. Newton is going to put that on exam. So my questions, all right? But it stands to reason why you don't give it concurrently or concomitantly. Let me just go back one. I just want to point out EGFR here. Interestingly, EGFR is expressed in many breast cancers more so than HER2. If this is so, what could be the role of EGFR in breast cancer? Because we know that there's high expression on EGFR. Could this be another target for treating patients with breast cancer? Well, let me just go back. And I think, Chris, you probably saw this before because we did this about 2 years ago when we were doing colon cancer. Here's just a schematic of EGFR. This is another transmembrane receptor in the HER2 family, also called HER1. You can see it has multiple effects on many tissue systems, multiple ligands here. And studies had done was if you knock out the receptor, what would happen to the mice who were EGFR knockouts? I'm going to go show you a couple of things. One, something happens in the central nervous system. And these are mice who have undergone necropsy. After knocking out EGFR, all of the mice died within a few weeks after birth, having this receptor knockout, suggesting the importance of EGFR signaling in the mice. Here's a picture of the brain. What you see in the red on the right are apoptotic cells compared to what's normal here. A number increase in cellular apoptosis in EGFR knockout mice. If you do a sagittal cut and you turn it on its side, one can see a marked diminution of part of the lobe of the brain. And again, all the mice died after having this particular receptor knocked out. Suggesting the importance again of EGFR signaling. Just EGFR alone now, knockout. Okay, so what could be the importance of EGFR? I think this is one reason why it might be important. If you just do an anti-EGFR therapy in patients with breast cancer, in spite of the fact that many of them express EGFR, it doesn't have any effect by just blocking EGFR signaling. None whatsoever over not using the drug. Okay, so you can just block the kinase domain here with a drug like gefitinib, and it does nothing to the breast cancer compared to no gefitinib. My thinking is that because they have to dimerize, remember I told you the receptors have to dimerize, well, HER2 does not only dimerize with another HER2. It can dimerize with any member of the HER family. And this heterodimer, the HER1, HER2, is more potent in terms of signaling than the HER2 homodimer. So, if you give somebody trastuzumab, it does not block signaling through HER1. So what did they do? They came up with a dual kinase inhibitor. And Dr. Newton may have already told you about this. This drug is called lapatinib. Lapatinib. This is a dual kinase inhibitor. It inhibits the kinase domain of both HER1 and HER2, so it can shut down this heterodimer. It has been shown to be effective in patients who have failed trastuzumab therapy or who have disease progressing on trastuzumab therapy. Switch them over to lapatinib, and these patients again responded to therapy, suggesting again that part of the signaling or driving force for growth and proliferation was this heterodimer, the HER1, HER2 heterodimer. So that's two drugs. Lapatinib was the second one. Now, HER2 can also dimerize with HER3. And I'll tell you what's interesting about this heterodimer, and you don't have to remember this, but this is one of the most interesting things about this particular heterodimer. HER3 here, notice I didn't put the kinase domain in HER3. And in fact, HER3 has a deficient kinase domain. It doesn't appear to have a functional kinase domain in HER3. So it does not signal by itself because of the lack of the kinase domain. The other interesting thing about this particular heterodimer is that HER2 does not have any known ligand. Okay? So you ask me then, how does the HER2 homodimer signal? When it homodimerizes, it's constitutively active. It doesn't require a ligand. Under normal circumstances, though, HER2, there's been no ligand that has been found to bind to HER2 as we know it today. So the interesting thing here is that there's no ligand for HER2, and HER3 is kinase deficient. And yet, this has now been shown to be the most potent signaling heterodimer of all four combinations. The most potent. So, could this then possibly be driving some patients who have HER2 positive breast cancer that do not respond to trastuzumab? And the answer is could be. So what did they do? They tried to look for another agent that could potentially inhibit this dimer formation. And now, a few months ago, this drug was approved. It was approved based upon clinical trials showing that it, in fact, was able to cause further regression in patients with HER2 or trastuzumab refractory breast cancer. One can use pertuzumab. But the interesting thing about pertuzumab that differentiates it from trastuzumab is that pertuzumab prevents heterodimerization. Okay? So it can block HER1 from binding to HER2. It can block HER3 from binding to HER2. So that's the beauty of this one. So it's a little bit different from trastuzumab in terms of its mechanism. Trastuzumab does not block dimer formation. Pertuzumab does. Okay? Now, do you have to remember that? No. I'm not going to ask you a question about pertuzumab. But this is one of the newest antibodies for HER2 positive diseases. And here's the newest one. Last week, this drug was approved for HER2 positive breast cancer in women progressing on trastuzumab therapy, trastuzumab emtansine. Now, this drug is a little bit different from trastuzumab because of this portion here, the emtansine. Emtansine is a maytansinoid derivative, and what that means is this. This is a chemotherapy agent. It is linked to the antibody. Okay? So this is known as an antibody drug conjugate, or ADC. Antibody drug conjugate. So here's the monoclonal antibody, here's the chemotherapy. This chemotherapy alone was tried in patients with leukemia, was found to be very effective, but far too toxic to be used. What they did was they made an analog of maytansine, and it was called emtansine, and finding that because now the drug was being targeted to the breast cancer cell, that one could see the antibody effect and the chemotherapy effect being somewhat more specific for the tumor cell. Remember, now part of this, and this gets in because the receptor complex here is internalized, taking in the chemotherapy, and then it is cleaved. The chemotherapy is cleaved after it is internalized. So kind of neat way that they did this. So just remember this, antibody drug conjugate. The drug alone, far too toxic to be used, but now they link it to an antibody that directs it to the tumor cell. Okay, so now we went from 1 to 4 agents for HER2 breast cancer, or HER2 positive breast cancer. And here's the list of them. Trastuzumab, again, targets the external domain. Lapatinib targets the internal tyrosine kinase domain. It is both HER1 and HER2 tyrosine kinase specific. Pertuzumab here prevents dimer formation. And the drug that I told you about is called TDM1 also. Trastuzumab emtansine antibody drug conjugate. Okay, not going to ask you a question on TDM1 or pertuzumab or lapatinib, but there will be questions on trastuzumab. Okay. Yesterday, I had mentioned, besides when I mentioned 6 hormone receptors, when we think of breast cancer, usually we only think about ER and PR, estrogen receptor, progesterone receptor. I had put down under risk factors, could androgens also be involved in the pathogenesis of breast cancer? There's been some intriguing new data about the androgen receptor that I'm going to tell you, but this is still in the very early stages. The androgen receptor has been found to be expressed more often or more frequently than the estrogen receptor in women with breast tumors. That's very, very intriguing. 3/3 or 2/3 or 3/4 of all of the breast tumors are AR positive, androgen receptor positive. Now they're trying to figure out, well, what's the significance of this? Is it because AR or androgens are also driving the disease, or could AR be causing a regression of the tumor? And that's been somewhat difficult to sort out. But the one most interesting studies was this. In cell culture, if you transfect the androgen receptor into tumor cells and you incorporate the hydrotestosterone, which is known to have very high affinity for the androgen receptor, what happens is that there's rapid proliferation of the breast cancer cells, androgen-induced proliferation. This is independent of any estrogen effect. It is androgen-driven. However, if EGFR is also signaling in that receptor, what happens when you add the hydrotestosterone is that it causes a decrease in proliferation, suggesting again that EGFR and the androgen receptor, if it is signaling, could have a beneficial effect if you target the androgen receptor also. Now these are all very, very new data. I don't expect you to know this, but just keep in mind that although estrogens play a primary role in the pathogenesis of the disease, now we're wondering what's the role of the androgen receptor in this particular disease. More will be known about this in the coming years, but I find this very, very intriguing at this point in time. Okay, so here's the woman. She has finished her chemotherapy. She's doing very well. Complete 5 years of tamoxifen, which is generally considered to be the optimal duration. Now, that's a caveat. Up to this year, the standard duration of tamoxifen in an adjuvant setting was 5 years. However, there's been a new study of the findings that were presented that shows that 10 years of tamoxifen is better than 5 years of tamoxifen. Now, I don't know if that's going to be accepted as a new standard, but we're going to have to wait and see. But these findings are very intriguing, whether or not continued tamoxifen therapy is better than just 5 years alone. But 5 years currently is the accepted standard. I put this down, should they be considered for additional 5 years? Maybe. Maybe in the next coming years, the guidelines are going to change, suggesting that 5 additional years may be better than 10. And I didn't ask you a question about zoledronic acid, and all of you know what the bisphosphonates are. Most of your association with the bisphosphonates come from the community setting where you've dispensed bisphosphonates to women, and usually it's postmenopausal women, to prevent bone breakdown, or prevent osteoporosis, or maybe in patients with osteopenia, the bisphosphonates. But you have to remember that when you remove the effect of estrogen, this certainly is going to have an impact on bone. Currently, zoledronic acid is not being recommended for all women on anti-estrogen therapy. But in patients who receive the aromatase inhibitors, there is a potentially good rationale for including a bisphosphonate. Now remember the big difference also. If estrogens have an important role, and you know that, right? Because the incidence of osteoporosis or osteopenia rises after menopause, suggesting that estrogens had a beneficial effect. Chris? Why would, in your opinion, zoledronic acid, which is a very potent bisphosphonate, perhaps not be indicated with someone who is taking tamoxifen versus someone who is taking anastrozole? I want you to think of the effect both of these agents have on bone. Go on. You're right. I'm sorry? On bone. Yes. It appears to preserve bone mineral density. But if you take away the synthesis of estrogen, i.e. with an aromatase inhibitor, then basically you've deprived the bone of estrogen. So big difference, right, on the bone. Although one would think intuitively, if you use an anti-estrogen, remember now it's not a pure antagonist. It has some beneficial agonist effects as well as some detrimental agonist effects. So it's not a pure anti-estrogen. So these are the kind of things that I want you to just think about. Don't just remember that, but think about when you apply it to the clinical situation, why? Just why? Why would one not necessarily have to have a bisphosphonate and the other one maybe should? Again, in contrast to patients with a diagnosis of aggressive lymphoma, an acute leukemia, where disease-free interval of, let's say, 5 years, and by that I mean no treatment now, disease-free without treatment, is believed to be cure. This does not apply to all cancers. For women with breast cancer or a diagnosis of breast cancer to be considered cured, that arbitrary time frame is approximately 15 to 20 years disease-free. Okay, and that means off of therapy also. So much longer period of time that this woman needs to be followed. But the likelihood of relapses occurring, let's say after the first 2 years, gets smaller and smaller the longer the duration of follow-up. Okay, so that's early breast cancer. And by early breast cancer, it's usually mean what's potentially curable, 1, 2, 3. But remember, stage 3 breast cancer, the curative rate is lower than stage 1 or stage 2. So the increasing in stage, the curative rate goes down, but not 0. Stage 4 is essentially 0 for cure. So in patients with a diagnosis of advanced breast cancer, let's say at the time of diagnosis, which tends to occur approximately 10 to 20% of all women diagnosed with breast cancer, only a small minority, but significant minority of women, 10 to 20%, have advanced disease at the time of diagnosis. Now note, in terms of the approach, you look at menopausal status, again, whether it's pre-post, ER, HER2 is also looked at. What's not important at this point is the nodal status, because the patient's got metastatic disease, so the nodes already does not mean anything. And the likelihood that the nodes are going to be positive is almost 100%. So, notice that the nodes are not in here, but ER and HER2 are, because again, prognosis and 2, treatment. Okay? And again, I just want to reiterate, and I know you have this, ER-positive tumors are treated with hormonal therapy. HER2-positive tumors are treated with anti-HER2 therapy. In spite of the fact that we've got 4 drugs to treat HER2-positive breast cancer, first-line treatment is still trastuzumab. And notice number 3 here. Chemotherapy or radiation therapy, again, may be first line, even in patients with hormone receptor positive disease, if the disease is considered to be life-threatening. Okay? Please remember that now. Just because a patient has ER-positive advanced breast cancer, that does not necessarily mean the patient should receive tamoxifen aromatase inhibitor first. It could be preempted based upon where the disease is. If it's bone-only metastatic disease, usually it's endocrine therapy. But think about where else breast cancer tends to go. Liver is one of them. The patient has got significant liver involvement with breast tumor. We know that anti-hormonal therapy isn't going to work that well and that quickly. So the patient usually is getting chemotherapy first. So ER-positive breast cancer, just because it's ER-positive, doesn't necessarily mean it's not going to respond to chemotherapy. Please remember that, okay? Breast cancers tend to respond to chemotherapy across the board. It's quite uniform, regardless of ER status. The ER status just says that endocrine therapy is likely to work also. Okay, please remember that. ER-positive does not necessarily mean chemotherapy won't work, or radiation therapy won't work, because these are effective therapies that can be used appropriately. Remember, about 50% of all women will probably like or receive radiation therapy at some point in time. Okay, so here is what I had put down before, and here are some things that we can use in the advanced setting. Now notice one thing. Whatever we use in an adjuvant setting for early breast cancer can also be used for advanced breast cancer. Okay, so any of these could be used for advanced breast cancer, any of them. But here are many other agents, and some that I did not even put down. And even though I put down single agents here, many of them can be used in combination, so the combinations can differ. And that's why I didn't want to put down all the combinations. But as you can see, compared to another hormone-dependent tumor like prostate, breast cancer has got far more chemotherapy options. And I believe Dr. Newton went over the treatment of prostate cancer, but when you talk about prostate cancer, you have very few chemotherapy agents, like docetaxel could be one, but very, very few chemotherapeutic options compared to breast cancer. So all of these are known to be effective. Usually, again, in a patient with newly diagnosed advanced breast cancer, a combination of adriamycin and cyclophosphamide is not uncommon in terms of treating initially. One can also use weekly paclitaxel, that's fine. But just remember here also, if the patient's ER positive, HER2 positive, always think about, in addition to chemotherapy, the addition of the other agents. Okay? So it applies whether it's early or late. Do you have to memorize this? No. Okay. remember all the statistics that I put up yesterday? Well, here are two more. As I said, or as I mentioned just a little while ago, approximately up to 20% of the women will have advanced disease at the time of diagnosis. But perhaps the more important one is this. Even those with early disease, a significant portion are going to relapse. In other words, we're not going to cure them anymore. So of the, let's say, 80% of the patients with early disease, 30% of them are going to relapse with advanced disease. So the question then came up, knowing that we are unable to cure metastatic breast cancer, is there a way that we could actually prevent breast cancer in and of itself? This is perhaps one way, prophylactic bilateral mastectomy. But this is a very, very tough decision to have to make. Because, and again, the women who opt for this or who are presented this as an option are women with known very high risk factors for development of the disease, such as BRCA1 and 2 mutations. Again, that particular mutation is associated with about an 80% risk that you're going to develop the disease sometime in your lifetime, 80%. So this is given as an option. Now, on the other hand, could we prevent this with a medication? And some of you may have already heard this because this is not new news. But tamoxifen, approximately 10 years ago, was shown unequivocally to result in a 50% reduction in the incidence of breast cancer in women who took the drug prophylactically. In other words, they did a study that identified women with high risk, not those with early breast cancer, patients at high risk for developing breast cancer, and put them on a trial that compared tamoxifen to placebo. And basically the endpoint was the incidence of breast cancer. In tamoxifen-treated patients, the reduction was approximately 50% fewer breast cancers in a tamoxifen-treated group compared to the placebo group. Now this was made, this was widely publicized by the NIH. It was also published in one of the most influential journals, and yet chemoprevention has not really taken the nation by storm. Family doctors are somewhat reluctant to prescribe tamoxifen to women who have a high risk of the disease. And in part, it's because of the treatment-related toxicities associated with tamoxifen, right? Clots can occur, and the clots could be fatal pulmonary embolus. We know now also that tamoxifen is associated with endometrial carcinoma, and hence that also somewhat precludes the women from wanting to participate in a study or to take the drug for up to 5 years. And the other thing was that in order to see a benefit, we will have to treat thousands of women to see the few that will benefit. So tamoxifen really hasn't taken over and become something that is currently done routinely. But there was another study that was published, and it was called the STAR study. And this is a study of tamoxifen against raloxifene. Now, some of you may have prescribed raloxifene, I believe. It's primarily indicated for osteoporosis, raloxifene. It is also an anti-estrogen. And when they did the STAR study, the study showed one. This anti-estrogen, which is prescribed to prevent osteoporosis, raloxifene, had very good breast cancer protective effects also, equal to tamoxifen without the endometrial stimulation. It has far less effects on clotting disorders, such that raloxifene now is an option to be used in the prevention of breast cancer with minimal toxicities and some beneficial effects not only on bone, but also on breast cancer. So raloxifene. Now the downside about raloxifene is they did the study only in postmenopausal women. So it's currently not known whether or not the premenopausal women will benefit. I suspect they will. I suspect they will. But since the study was done only in postmenopausal women, to date, currently, the only drug that's been shown to reduce the incidence of breast cancer in premenopausal women is tamoxifen. But raloxifene then becomes a very good option for postmenopausal females. And this is what I had mentioned. The other thing that should be told to a potential woman who is considering prevention of breast cancer is that the toxicities associated with these drugs tend to occur only during the period of treatment. But there appears to be an anti-tumor carryover effect of about 5 years after the drugs stopped. And I have to point out one more thing. The endometrial carcinoma, while it is statistically significantly increased in patients receiving tamoxifen, the actual numbers are very small and the tumors are usually very low grade endometrial carcinoma. The other thing was this. A number of years ago, some investigators started to look at whether or not pharmacogenomics could identify women who should receive tamoxifen or who should not receive tamoxifen. And there are two students in this class who know more about this than I do, but I'm not going to put you on the spot, Sarah or Kristen. Basically what they found was this. The studies showed, at least the initial studies showed, provocative data about patients who were CYP2D6 deficient or had taken drugs that could inhibit 2D6 would not benefit from tamoxifen. And in part is because 2D6 metabolizes tamoxifen to its active metabolite called endoxifen. All right? So when this study was published, they felt that, well, why don't we do pharmacogenetics? And if a patient is 2D6 deficient, then they should not receive tamoxifen because the benefits don't outweigh the risk associated with the drug. However, there have been some new studies that are not consistent with the earlier studies, although most of the studies suggest that 2D6 genomics could identify or could be used to identify who should not receive tamoxifen. So it's still up in the air regarding 2D6. Okay, I think this is about my second to the last slide. I'm just going to separate out what's fact and what's real. One fact, 60 to 70% of all women who have a diagnosis of breast cancer will be diagnosed at an early stage. Just remember though, that approximately a third of them will relapse. In spite of appropriate therapy. Fact, mammograms have unequivocally shown to reduce mortality, and hence it is a screening tool of worth. The reality is that it's usually the postmenopausal women who benefit from mammograms. Another fact, sentinel node biopsy, if positive, we may be able to circumvent having to do complete axillary dissection and the known morbidity associated with that procedure. However, the reality is that if the sentinel node is positive, what about the distal nodes if complete axillary dissection is not performed? Could they have an impact on disease recurrence? It's possible. There's still some question whether or not, if the sentinel node is positive, do we still need to do complete axillary dissection? Two other facts. Again, ER is predictive. The presence of the estrogen receptor is predictive that it'll respond to hormonal therapy. And again, this is not just tamoxifen. This is any form of hormonal therapy. But the reality is that not everyone responds, in spite of the fact that they express the estrogen receptor. HER2 also is predictive of response to anti-HER2 therapy, but again, not all the patients respond to trastuzumab, even if they are HER2 positive. Suggesting again that maybe the heterodimers may be very important in some of them. Here's another fact. By giving endocrine therapy or HER2 therapy in an adjuvant setting, it has definitely led to an improvement in survival. However, a significant number of patients are going to progress in spite of appropriate hormonal or HER2 therapy. And one that I want you to remember is this. While tamoxifen and raloxifene has been shown to have a significant impact on reducing the incidence of breast cancer, the breast cancer that is avoided or decreased in incidence is ER positive breast cancer. Does not appear to have an impact on ER negative breast cancer. Okay, let me just ask you a question. Was this on the exam? And the reason why I ask is because I did not see the exam. So I did not know which questions Dr. Newton took. Was this question on the exam, Michael? It was. It was. All of you remember this question? Okay. Now I've got to ask someone. Is Sal here? Sal. Again, I don't know what answer you selected, so I'm not trying to put you on a spot or anything like that. But you remember which answer you selected for this? And basically the question is this. Here's a drug that is approved by the FDA that has been shown to decrease renal toxicity when given in conjunction with cisplatin. Okay? Cisplatin is known to have renal toxic effects. So when given concurrently, it's been shown to reduce the nephrotoxicity of cisplatin-based therapy. But what is also true is that if you look at the studies, some of the studies show that it antagonized the effect of cisplatin, i.e. tumor responses were a little lower when the combination was given. Based upon this true information, which one of these would be most appropriate? I'm sorry? D? Why did you select that? So that's correct.
I just remember putting that.
But you had no reason? You didn't guess though, right?
I don't remember why, I just remember putting that.
Okay. For any of you who did not select D, D is the most appropriate answer. And here's the reason why. Oh, let me just ask, did someone take another answer? Sarah, did you take another answer? You took D? Okay. Did all of you take D? There's a reason why. There's a reason why I'm bringing this up, because I have another question similar to this. So I want to make sure that you understand the concept behind this question. All right, if you did not take D, here's a situation where a drug has a known toxic effect. I also gave you information about another drug that could decrease this potential toxicity. But I also told you that when given in conjunction, there are some studies who showed a decreased response. Okay, the crux of this question, and the most important part of this question, is that in oncology, especially when we're dealing with a curable cancer, I'm using curative here now, you're going to treat with curative intent, you do not do anything that could potentially antagonize or decrease the outcomes. Nothing. Because we may have one chance and only one chance to cure the tumor. So here's the part. So Sal, if you told me that this part here is troublesome, a decrease in tumor response and you put this in conjunction with a patient who has had a diagnosis of testicular cancer, which is a very highly curable cancer, that one, you don't want to take any chance in decreasing the outcome. None whatsoever. Okay, please remember that, because you're going to see another question similar to this, similar to that. If you have an opportunity to cure someone of their particular disease, I don't mean just palliate, no, I'm talking cure. Cure. If the treatment is of curative intent, and you're telling the patient that we're going to try and cure you, not just decrease your tumor, decrease the size of tumor. The outcome that we're striving for, the goal is cure, then we do not do anything that could potentially decrease the response to therapy. Okay, remember that. Please remember that. Okay, Michael, you're going to be disappointed. Here's my exam focus, chronic leukemia and breast cancer. Here's something. Now, if I have any other things I want to, as I'm writing the questions, I'll add it to this, and I'll tell Dr. Newton to just post it. But as of right now, please know what the natural history of CML is. Okay? Natural history. And basically what that means is, untreated, what's the natural history? The patient has a diagnosis of CML. What happens if you don't treat? I want you to know absolutely the impact of what imatinib has done to this particular disease. I'm not asking you how the drug works. Not asking you that. I just want you to know the impact, because it has had a profound impact on CML. Amy, is this an oncogene? BCR-ABL is an oncogene. I've created a question about this oncogene that's a little bit different from the one that you saw in the exam. Okay? The BCR-ABL oncogene. Okay, in CLL again, I want you to know by here I say certain features of the disease. Don't just memorize that this is a B-cell disorder. Think about what the implications of the B-cell disorder has. Okay? And the one thing that comes to mind is B-cells, antibodies. So it's going to affect the immune system. Because this is an incurable disease as we know it today, many supportive care strategies are used in patients with CLL. Just go over some of the supportive care strategies. Again, I'm not asking you to memorize what they are. I want you to be able to apply it in a clinical situation. Here's another one. All of you know what BCL2 is? Anybody? Anybody? Everybody putting their head down. Carol, you remember what BCL2 is?
It is what's in lymphoma, the gene.
But what does it do? What's its function?
Apoptosis.
It has something to do that, but what? BCL2. Okay, let me just ask you this, Carol. Does it promote apoptosis or is it anti-apoptotic?
Could be anti.
Yes. It's a pro-survival protein. You'll see a question on BCL2. Not that it's anti-apoptotic. That I expect you to know. I just want you to think about something else associated with that. Okay? Just know though that it is anti-apoptotic. Okay, I'll give you a little bit more of a hint on what's going to be asked. There is now a drug that targets BCL2. IEE is anti-BCL2. And what could happen when you target BCL2? Okay, I think the majority of 10, 20, 10, maybe a little bit more than the majority of the questions are going to be on breast cancer. Know what these two terms mean. And I don't mean just memorizing what they mean, but can you apply it? Keep in mind the prognostic factors or features that we talked about with breast cancer. Adjuvant chemotherapy and hormonal therapy. Perhaps the one that I want you to know more is the adjuvant hormonal therapy, and not necessarily chemotherapy. Most, if not all, of the types of endocrine therapies, including oophorectomy. Please know this for both tamoxifen and the aromatase inhibitors. And as I mentioned to Chris, there is a question specifically related to bone. Even though this was covered early on, I believe I have a question on whether or not one can participate in a clinical trial with a new diagnosis of breast cancer. And the answer is yes, you can. But it's got to be an appropriate clinical trial also. Everything on the exam except for that amifostine, cisplatin, I've mentioned in class. The other issue revolves around the same thing that I had mentioned regarding the amifostine cisplatin. It is analogous to that. The case is going to be identical, but just using two different drugs. Okay? The case is going to be somewhat identical. All right. Now, as I get a few more questions, I'll be there at this exam. Let me just tell you this. During the exam, should you need me to clarify anything, ask me, because it could mean getting it right or getting it wrong. And a simple clarification could make all the difference in the world. So just ask. Just ask me. And don't ask me, what do you mean by this? I'd like to have something a little bit more specific than that. Okay? All right. I'm going to end right here.